Thank you. So welcome to breast and reproductive health. So starting for one of the last times with our brain bender of the evening, has anybody had a chance to work it through and want to share their answer? Okay. 31 drops per minute. And remember with the order, because it says how many drops per minute would the IV run. That's another way to differentiate between whether we have a pump or not. There are no rounding instructions, but with drops per minute or not having a pump, you have to round automatically. So when we get to 31.25, we know we're going to round to a whole number for drops, so we look to the right of the decimal. That's a 2. That's less than 5, so it stays 31. And 2, 4, here. And I'm going to go over to Blackboard just to point out a couple things. Not really, but it's what I want to get to. Okay. So a couple of things as noted in the post for the upcoming week. Remember, next week we'll have our final exam on Monday. Make sure you have your appointment set up in Blackboard. You'll have 120 minutes or 2 hours to complete 95 questions. And there's not a set makeup for the final, the way there are for other exams. So please do everything you can to be there for your appointment. There is also a blueprint that was uploaded to Blackboard, and this will show you the breakdown of where each of the sections of questions are coming from. So because we have 95 questions, it's roughly kind of 2 exams in one, about. So there are going to be math, but there's more math than we've had on other exams, to be prepared. The areas we've already tested on, peri-op and ortho, respiratory acid base, diabetes, fluid electrolytes, renal, and hematology, HIV, oncology, those you notice are all less than 10 questions on those areas because you've already been tested very, very, very in depth, right? But you've already been tested on a whole test of just those questions. So yes, the final is cumulative, and what this is each content area, and then here's the number of questions that'll come from each area. And just that can be quite intimidating. Believe me, I understand that. But think of it this way: is that you've already been tested on those areas. To a 40-question test just on those areas, and now we're going to 8 and 9 questions. So they're more the kind of big ideas, main concepts, main disease processes talked about in those areas because you've already been tested in depth on the other exams. That one exception to that is the breast and repro here, as this is the content we're going to cover today. And as you see, it's the largest chunk of questions. So the breast and repro questions are going to be at the level you're used to that we've had up to this point. So think of the 35 questions, that's your breast and repro exam. So whatever you've been doing to prepare for an exam, do that with the breast and repro material. And I would definitely still suggest reviewing the other materials, especially the earliest stuff, because now you've had the benefit of multiple exams and multiple experiences with the NCLEX style questions, kind of looking at that, especially like peri-op and ortho, with the benefit of that experience. And or if there was a test, or more than one, that didn't go so well, kind of reviewing that material, again, with the benefit of more experience with the questions. And as you're studying through these, you can kind of use NCLEX questions as kind of a checkpoint. Like for diabetes, for example, say you're studying diabetes, you're looking at the complications, and so you do some questions on DKA and HHS. Okay, if you don't remember what those are, make sure you look at them up. But say you get all the DKA ones correct, but you don't do as well with HHS. Then you know, okay, I need to spend more time reviewing the HHS material. It may help to kind of direct you where to best spend your time. Because we all like going over what we already know. That gives us a boost in our confidence, and there's nothing wrong with that. But remember, you want to make the best use of your time and got to put the most time into areas where you're not as strong. But also thinking of it as we have a patient dealing with these conditions that is still consistent throughout. So if I have a patient in front of me, how would I know something's wrong? How would I identify what is wrong? And what would I do about it? Especially what would I do first? That will help. So coming back over here. Okay. So the way I have this set up is kind of similar to last week, where we'll talk about some of the material, then we'll do a shorter case study, and then we'll do another set of the material and a case study. So the case studies have been uploaded to Blackboard. I think I just put them under the breast online lectures because that was the first one. And then I'll upload an answer key when we're done. But these are also embedded in the PowerPoint. Here we go. Oh boy. It's going to be long. This is going to be a long night now. So first to talk about breast disorders. I have the benign conditions here, and then we'll talk about breast cancer. Because some of the breast disorders may increase the patient's risk of developing breast cancer, but not all of them. So we'll kind of talk about each one specifically. So the first one I want to talk about, and I'll have usually pictures on these if I can, just to help give you an idea of what we're looking at. Picture's worth 1,000 words. And so fibroadenoma is a mass of connective tissue unattached to the surrounding tissue. And so it is mobile, it can move, and it can occur anywhere in the breast. It's most often discovered by patients doing breast self-exam or mammography. And these tumors, they are considered a tumor, but they're oval, freely mobile. They're oval in shape and then freely mobile in that they can move, and rubbery in texture. We may use a needle aspiration to determine if it's cystic versus solid. Cystic would mean fluid-filled. And risk for cancer developing from a fibroadenoma is very small, but it depends on the individual fibroadenoma. Some may evolve into breast cancer, but it would depend on a specific one. And that's why we may do more testing. Somebody's not muted here. Please make sure you're muted. Fibroadenomas may be left in place and monitored because some may stop growing or shrink on their own, or they may be excised with a local anesthetic. So this would just need something applied right to the site to numb it, and then removal right there. It wouldn't necessarily need general surgery. So the next benign condition is fibrocystic breast condition. These is kind of a catch-all term, but it involves changes involving the lobules, ducts, or stromal tissues in the breast. And this most often occurs in patients who are teenage years or in their 20s up to 50 years old, although it usually subsides after menopause. It's thought to be caused by an imbalance in the estrogen to progesterone ratio. And symptoms include breast pain, tender lumps, and swelling. Fibrosis and cysts may develop. Fibrosis is the replacement of normal cells with connective tissue and collagen. And cysts are the fluid-filled areas lined with gland cells. These breast conditions or breast changes are more noticeable before menstruation, and symptoms may resolve post-menopause. Recommendations for treatment may include to limit salt intake before the menstrual cycle to decrease swelling, encouraging the patient to wear a supportive bra even to bed, administer diuretics to again help decrease swelling, and or local application of heat or cold therapy to relieve the breast pain. Ultrasound and a needle biopsy of the lump may occur, and this may also be used as needle aspiration to drain a cyst to relieve the pain. But fibrocystic breast conditions do not increase the patient's chances of developing breast cancer. They do not. And these are a couple of examples here. You can see the fibroadenoma as well as the cystic breast changes. So the cysts have fluid in them. The fibroadenoma does not. It's just replacement of the normal cells with connective tissue and collagen. So next we have ductal ectasia. This is where the breast duct dilates and the walls of the duct thicken, causing a blockage. And you kind of see it over here on the right. Normal duct, we have the ring of cells and then it's open. But here clogged, here we have the ring of cells and there's a blockage here. And the wall has thickened and actually blocked off the duct. And the duct, you can see here, it's a little small, but it's this reddened area here, which would mean that then the milk can't come out to the nipple and then be passed to the baby. And in ductal ectasia, the mass may feel hard and irregular borders may be detected. It may be tender to the touch. We may also see greenish brown discharge, enlarged axillary nodes, and redness and edema at the site. And ductal ectasia is usually seen in women approaching menopause. They may present with a hard, irregularly shaped mass or masses with nipple discharge, enlarged axillary nodes, redness, and edema. And some of these are similar to cancer, so it can be difficult to distinguish from cancer. But ductal ectasia does not affect the patient's risk of developing breast cancer. Ductal ectasia may improve without treatment, and warm compresses and antibiotics may be helpful. If, though, the symptoms do not improve, the affected duct may need to be surgically removed. So those are kind of the more common benign conditions. Now I want to talk about breast cancer types, and then we'll do a case study after that. So in your book, we also have some information that talks about the risk factors for breast cancer. It might be helpful to look at what would increase the patient's risk. There are also some tips for breast cancer prevention, if we can prevent it, treat, or detect it at its earliest stages. And the 3 ways to detect it as early as possible is 1, breast self-awareness, and actually breast self-exam or breast self-awareness, they're usually considered equivalent, but just the patient being aware of what their breast tissue presents like at different points in their cycle is helpful, just as helpful as a breast self-exam. But the face of the clock method can be used to document, the location of any palpated masses. And with a breast self-exam or breast self-awareness, we want to inspect the entire breast, palpate every inch, including compressing the nipple to check for drainage. So to help prevent or detect cancer at its earliest stages, breast self-awareness. 2, mammography. and a clinical breast exam, these three together have better detection rates combined than any single test. And previously, the American Cancer Society recommends beginning mammograms for patients in their 40s, but the U.S. Preventative Services Task Force, or the USPSTF, there's an acronym for you, initially recommended beginning mammograms for patients in their 50s. But there was such an outcry because we're seeing breast cancer in younger and younger patients that they kind of backtracked and said, "Oh well, patients should individualize their care with their physicians." And white females over 40 years old have the higher risk, of developing breast cancer than other racial ethnic groups, but African American females have the highest mortality rate with breast cancer, especially in those younger than 40 years old. So it's something to be aware of. Even in our younger patients, sometimes they can have, they may not be thinking that they have breast cancer, or we'll talk about in a minute, they can have a form that doesn't present in your typical symptoms, what you think of for breast cancer. That men may also develop breast cancer, although it is usually more rare. But males tend to have a lower survival rate than females, especially African American males, also because they don't think they can get it, because I don't have breasts, but they have similar tissue, and that tissue can develop into breast cancer. So it's something to educate our male patients about, as well as our minority female patients, to let them know, this still could happen to you. We need you to be checking yourself, but also to be, having regular tests like mammography or the clinical exams, so we can catch it as early as possible, because we're going to see in this minute, it is a nasty thing. So there are two broad categories. There's non-invasive, and then there's invasive. First, we're going to talk about non-invasive, and that basically means it's not moving outside of the area. It remains within the duct. And there's two types of non-invasive breast cancer. There's ductal carcinoma in situ and lobular carcinoma in situ. And in situ, to me, that sounds like in sight, and it's basically what it means. But so if you see the in situ, think that's the non-invasive. And I'm just going to go forward one slide just to show you. This was a bigger picture. When you have the breast structure, you have the lobes, which feed into the ducts, and then the ducts go out to the nipple. So ductal carcinoma in situ is going to be in the thinner tube here. And you can kind of see, here's a normal duct, and then here's the ductal carcinoma in situ. You can see the abnormal cells in a different color, and now they're growing kind of in irregular patterns, but they're still in the tube itself. They're not trying to spread out. And so ductal carcinoma in situ is located within the duct, we saw, and it has not invaded surrounding tissue. Now, this is being detected earlier, mostly due to mammography. And so we're seeing an increase in the number diagnosed, but that's because we're getting better at detecting it. So even though the detection rate's on a rise, that's actually a good thing, because we're finding it sooner. But if a ductal carcinoma is left untreated, it's estimated 14 to 53% could become invasive. So ductal carcinoma could change into invasive, but we don't know any way to predict which ones will and which won't yet. So if you have a patient diagnosed with ductal carcinoma in situ, we most likely will not be leaving it alone, because there's a chance that over half of these could become cancerous. Now, that was ductal carcinoma. And then we also have lobular carcinoma. And I'm going to go back to that picture for a second. So the ducts are the tubes here, and the lobes they kind of look like a bunch of grapes that lead into the ducts. So, and here's the kind of cross section of a normal lobule. And here's the lobular carcinoma in situ. Again, the irregular cells in a different color and growing in an irregular pattern, but for the moment inside the lobe. text, lobular carcinoma in situ is more rare, and it occurs as an abnormal growth, like we saw, in the lobules of the breast. It's usually diagnosed in patients before menopause, between 40 and 50 years of age. However, lobular carcinoma in situ is not actually a true cancer, but it can increase the risk of developing a separate breast cancer later. So that's kind of why it's still classified as a carcinoma. So ductal carcinoma, some of them may become invasive or spread, but we have no way to predict which ones. And lobular carcinoma can increase the risk of developing a separate case of breast cancer later. This is just going to show you the difference. The lobes are kind of what looks like the set of grapes here, a bunch of grapes, that's the word. And then the ducts come off of the lobes and into the nipple, kind of give you a perspective of what's going on where. So those were non-invasive breast cancer. So the other type is invasive breast cancer. So this is where the cancer penetrates the tissue surrounding the duct. So, and this is going to go out into other areas of first the breast or potentially the body. And we have two types. There's infiltrating ductal carcinoma and inflammatory breast cancer. So first, infiltrating ductal carcinoma is the most common type of invasive breast cancer. It tends to originate in the mammary ducts, but can then grow into the lining of the epithelial cells. It grows into the surrounding tissue in an irregular pattern, and the fibrosis can cause skin dimpling. And I apologize for anyone who speaks French in the audience because I'm not going to pronounce this correctly, but peu d'orange. Again, I apologize, do not quote me on that pronunciation. Infiltrating ductal carcinoma, if the lump is present, is felt in an irregular, poorly defined mass, and the skin dimpling, also known as over here, is a late stage edematous thickening and pitting of the breast. And to show you what picture's worth 1,000 words. So over here on the left, this kind of shows you what we mean by the skin dimpling. Okay. Then we also have inflammatory breast cancer, which is a rare form of breast cancer, but it's highly aggressive. And symptoms can include swelling, skin redness, breast pain. It seldom presents as a palpable lump, though you might see the skin dimpling. May not show up on a mammogram, and that was on the right side of this picture. So you see, it doesn't look like what we've looked at up to this point for breast cancer. So it may not be seen as that by the patient. They might think, oh, I've got a rash, or I got exposed to something, or something on the skin, but not thinking it's inflammatory breast cancer. And so it's often harder to successfully treat because it's usually diagnosed in later stages, unfortunately. It's not correctly seen for what it is at the time. But the only way to definitively diagnose breast cancer remains breast biopsy. So when in doubt, we're going to take some of the tissue for further testing. So speaking of testing and treatment, there are several forms this can take, and a lot of times they're going to be combined. You can definitely have non-surgical treatment, and complementary and integrative therapies are often used. However, these do not alter the outcome of breast cancer, and they can be complementary, but they are not a substitution for standard treatment. And this is where, with everything being online, we all know there are a variety of information online, some good, some not so much. So we want to, as nurses, direct our patients to the proper sources of information, and the website breastcancer.org provides accurate information about complementary therapies and the extent to which they've been researched in cancer patients, because sometimes they may be recommended by certain sources, but if they haven't been researched, then we don't know for sure about their effectiveness. And cost may be a factor in decision making, since not all insurances provide coverage for complementary therapies. But also remember to teach our patients that all ingested complementary agents potentially have interactions with conventional medications and drugs. So they need to tell us, we need to educate them that they need to tell us anything that they're taking, whether it's herbs or supplements, we need to know for their own safety. Also, there are surgical treatments that can be used with breast cancer, including breast conservation therapy, also known as lumpectomy, when they're trying to just remove the lump, just the tumor itself and a small amount of tissue around it to make sure they get anything that started to spread, rather than the entire breast. Whereas with a partial mastectomy is the surgery to remove part of the breast that contains cancer and some of the tissue around it. So mastectomy does not conserve the breast. The affected breast is completely removed. And a total or simple mastectomy is surgery to remove the whole breast that has cancer, whereas a modified radical mastectomy removes the breast tissue, the lymph nodes, and sometimes part of the underlying chest wall muscle. So we can go from just removing the lump to taking off the whole breast and then some. Breast reconstruction may be done either during the mastectomy procedure or after in a separate surgery. Is common with few complications, but no surgery is complication-free. There's always a risk. And patients consult with the plastic surgeon to discuss the type of reconstruction, timing of the procedure, and technique. And many women prefer reconstruction immediately after the mastectomy using their own tissue. That's called autogenous reconstruction, auto meaning self. And breast reconstruction at the time of the mastectomy procedure, either with their own tissue or a prosthetic, can lessen the psychological strain associated with undergoing a mastectomy, because that can be quite emotionally taxing on patients. Then we get into adjuvant therapy, where it's not a medication treatment, but it's still a form of treatment, such as chemo or radiation. And adjuvant therapy for breast cancer consists of systemic chemo, radiation, or a combination. So they may both be done, like we talked about a little last time, about how chemo can go more systemic, whereas radiation is more targeted. So radiation might be used to try and shrink the tumor growth, whereas the chemo could be used to try and get rid of anything that had metastasized or moved into other areas of the body. And chemo for breast cancer is going to be delivered systemically through a central IV. And its purpose is to kill undetected breast cancer cells that may have left the original tumor and are on the move. And it's recommended for treatment of invasive breast cancer, and invasive means it's growing into other areas of the body, so we're trying to target that with chemotherapy. Or we're trying to treat that with chemotherapy. Let me not use the word targeted, that's more radiation. Chemo may also be given before surgery to reduce the size of the tumor. Is most effective when combinations of more than one drug are used. And then radiation being more targeted to the specific tumor growth. They also can be used together. And drug therapy, you can also have chemo treated as a medication, where it can be IV, sometimes oral, but in the inpatient setting, it's usually IV, given through central access device, and maybe given before surgery to reduce the size of the tumor, more effective in a combination. Targeted cancer therapies are actually medications that target specific characteristics of cancer cells, like a protein or an enzyme these produce. And they have more advantages because they're targeted. They can kind of zoom in on the cancer cells more easily than our older medications, which just targeted kind of faster growing cells. Hormonal drugs may also be used in breast cancer prevention and treatment. And the purpose of hormonal therapy is to reduce the estrogen available to tumors to stop or prevent their growth. Although the suppression of ovarian function decreases breast cancer risk, the drop in estrogen may lead to menopausal symptoms, and so the decision to use these meds is not made lightly. Then we have some acronyms there, the SERMs and the AIs. The SERM stands for Selective Estrogen Receptor Modulators, which do not affect ovarian function the way other hormonal drugs do. They block the effect of estrogen in patients who have the estrogen receptor positive breast cancer. However, common side effects of these could include hot flashes and weight gain. More rare but serious side effects could include endometrial cancer and thrombolytic events. We also have aromatase inhibitors such as letrozole, Femara, and anastrozole, Arimidex. These are used in post-menopausal women, whereas some of the SERMs were used in pre. They were used in women who have estrogen receptor positive breast cancer, and the aromatase inhibitors can be used in postmenopausal women whose main source of estrogen is not the ovaries, but instead the body fat. And a side effect of these aromatase inhibitors, not seen with tamoxifen, is a loss of bone density. So then we know they could be more prone to falls risk and fractures, so they may be on medication to help strengthen their bones, such as meds that are used for osteoporosis. Then stem cell transplant is also an option because we can have two forms, the autologous or allogenic stem cell transplant. We talked about the auto before, that means self. So an autologous bone marrow transplant could be taken from the patient's own bone marrow. Peripheral blood stem cell transplantation taken from the circulating blood could be used, or we could have allogenic transplantation, which is taken from a donor, bone marrow or peripheral blood. This is performed as a means of rescue therapy after high doses of chemotherapy, because the chemotherapy is trying to knock out the patient's existing system, and then we're trying to put in a new system kind of in place with the stem cells that can then grow into any other type of cells. Check. Sure, I not missed anything. So have a case study here, and then these are available on Blackboard in the folder for this week. But we have patient VL, is a 68-year-old Asian woman who lives with her husband and is the mother of a 34-year-old daughter and a 32-year-old son. She has been a successful businesswoman and did not marry or have children until she was in her 30s. She discovered a lump in her left breast while bathing about 3 months ago, but has only now come to the clinic for examination at the insistence of her daughter. VL tells the physician she felt the lump a few months ago, but hoped it would go away on its own. And so the physician examines VL's breast and finds a lump in the left breast. So the physician notes the lump in her breast is non-movable, irregular when palpated, and is non-tender. And VL asks how it will be determined if the lump is cancerous. What would be the best response from the nurse? A. Tissue from the lump must be removed and tested to determine if the lump is cancerous. B. Mammography may be used to determine if the lump is cancerous. C. Ultrasounds may be used to determine if the lump is cancerous. Or D. If a lump is detected in the breast tissue, it is always cancerous. So what do you guys think? A, B, C, D. Already been. And it would be A, because we have to remove the tissue and test it to determine if the lump is cancerous, because what we looked at earlier were some examples of the benign conditions, some of which can present with more extensive symptoms than might be seen in breast cancer itself, but we still want to test it to be sure. So, diagnostic results come back. It is estrogen receptor positive malignancy, and the tumor size is 6 centimeters. So, treatment recommendations are a modified radical mastectomy or breast conservation surgery, the lumpectomy, with radiation therapy, and a sentinel lymph node dissection, SLND, with an axillary lymph node dissection, ALND, if the sentinel node is positive. As what that means is they'll look at the area and they'll find what node the lump has connected with, or is most likely to connect to. That's called the sentinel node. And they'll remove that and test it for any of the cancer cells. If the cancer cells are detected in the sentinel node, then they'll check the other nodes. But if the first one is clear, then they don't have to proceed any further because they know which one it would connect to first. So VL calls the clinic to ask which surgical procedure would be the best option. So which would be the best response from the nurse? A. Breast conservation surgery has a better survival rate than a modified radical mastectomy. B. For a tumor larger than 5 centimeters, a modified radical mastectomy is recommended. C. A modified radical mastectomy has the best chance of cure because more tissue is removed. Or D. Radiation therapy will increase the chance of cure. And then we may move in the chat boxes. Can't tell if those are new or not. Okay, got some new answers. Thank you. And that's a variety of answers. So it's actually B. For tumor larger than 5 centimeters, a modified radical mastectomy is recommended. And because with A, actually the survival rate of breast conservation surgery or the lumpectomy is about equal with the modified radical mastectomy when the lumpectomy is combined with radiation therapy. Modified radical mastectomy is recommended when the tumor is greater than 5 centimeters, and this removes as much of the breast tissue as possible, including the nipple and the areola and a number of axillary lymph nodes, but not the muscles. And so more tissue may be removed, but it doesn't necessarily have the best chance of cure, because if, say, she were to go for a lumpectomy, and they would take the lump and any of the tissue around it, and they determined, the tumor had not spread into the surrounding tissue, then that would tell us, okay, we've got everything. But just removal of more tissue doesn't necessarily mean this procedure has a better cure, quote unquote, rate. Because a lumpectomy could be as effective, but because the tumor is larger in size, we recommend the more involved surgical procedure to make sure we get everything. But radiation therapy in D on its own does not necessarily increase the chance of cure without removing of the lesions. So BL decides to have a modified radical mastectomy for her breast cancer, and she returns to the unit with a peripheral IV running D5W at 150 milliliters an hour, a patient-controlled analgesic pump, sequential compression devices, SCDs, on her bilateral lower extremities, and a hemovac drain with a compression dressing over the left chest wall. And the report from the PACU is that the patient is drowsy but breathing on her own and received a morphine bolus approximately 30 minutes before. So what would be the priority assessment or assessments, as we know how much you guys love Select All That Apply, for this patient? A, encouraging the patient to churn, cough, and deep breathe regularly. B, pushing the PCA pump for the patient every hour. C, assessing the color and amount of drainage from the hemovac. Or D, taking the blood pressure in the affected arm to assess circulation status. Remember, when you see Select All That Apply, look at each answer choice and think, if this were a single answer, would I choose this one? And then look at the next one and try that same thing. That might help. They're never easy, but that might help a little bit. They're looking for A and C, encouraging the patient to churn, cough, and deep breathe regularly, because that's going to help prevent respiratory complications such as pneumonia. That kind of harks back to peri-op and ortho and respiratory, because we want to get those respiratory secretions moving in the body. And we want to, also going back to peri-op and ortho, assess the color and amount of drainage from the hemovac. That's going to tell us how the wound is draining and healing. And B, only the patient should push the PCA pump. And although even if, say, the patient was sitting there and just went push, 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 so to speak, the machines have a lockout function, so they wouldn't get dose after dose after dose of medication. So even if they're sitting there constantly pushing the button, they're only going to get what it is programmed for. It has a lockout feature. And we do not like to take the blood pressure in the affected arm, because that could cause further issues. So we would take blood pressure in the unaffected arm. And so what are some exercises VL could be encouraged to do while recovering from her surgery? Select all that apply. A, running a marathon. B, hand wall climbing. C, weightlifting. D, pulley exercise. E, rope turning. No votes for the marathon, huh? Okay, put a few in there that were kind of obvious. So we want to be thinking of what would be appropriate for a patient, and at least right off the bat, running a marathon, no. Maybe if she had been a marathon runner, she could build back up to that, but definitely not while she's recovering. Hand wall climbing, and and this is where I miss not being in front of you guys, but if they had their two hands against the wall, and then they just kind of move their hands up one at a time, hand wall climbing, so that could be helpful. It's more thinking gentle exercise, so weightlifting would also be a no. Again, if she had been a weightlifter, she could work back up to that, but during recovery, that would be far too much, too fast. Pulley exercise would be recommended while she's in the hospital. That's where a rope looped around a pulley, kind of go back and forth, and rope turning, literally turning the rope with her hands. And again, very gentle exercise, especially in the early stages of recovery. And there should be a chart in the book that can help with post-mastectomy exercises. titled Patient and Family Education Preparing for Self-Management. I can give you some further descriptions of those exercises. And VL states her best friend had surgery for breast cancer, and the friend's arm became swollen after surgery. What would be the best response from the nurse? A. Swelling may be prevented by not exposing the affected extremity to sunlight. B. Compression devices may help to prevent swelling in the affected extremity. C. Avoid using the affected extremity to prevent swelling. Or D. X-rays of the affected extremity may detect early stages of swelling. And what is described in this question is called lymphedema, where you can get swelling in the extremities. And so actually the best response would be B, a compression device, and be used to help prevent swelling. And I've seen them, it looks like a anti-embolism stocking, TED hose, but made into a glove form. And so instead of going around the toes, it has finger spaces, and then it goes up the arm pretty far. I'm trying to think, I can't remember exactly how far some of them I've seen come up. It comes up pretty far, if not all the way to the shoulder, pretty close. And so this can help, just like an anti-embolism stocking would, to help keep the swelling down, prevent it, and but the patient can still use the extremity if they wanted to. Exposure to sunlight does not impact lymphedema, and X-rays are not going to detect it because those detect issues with the bone. So VL has an uneventful recovery from her surgery. At discharge, she verbalized understanding of her teaching and states she plans to return for reconstructive surgery soon. She thanks you for all you and the other staff have done, and the UAP escorts her and her family to their vehicle. And I have been told these end a little happier than the ones I did last week, or last time we met. So I said, I like these better, they're happier. So, that was benign breast diseases and breast cancer. Now we're going to talk about female disorders other than ones related to the breast. So we have endometriosis, which is implantation of the inner uterine tissue outside the uterus. And so you can kind of see in the image here, these lumps, if you will, are the uterine tissue outside of where they should be, because they should be inside the uterus here, and now they're outside. But the patient's menstrual cycle will still continue, and these tissue lumps or areas will still go through the shedding of the cell, of the layers, and everything, just in the wrong area. And so symptoms can include pain, infertility, and fatigue. So they may be treated by oral contraceptives to try and help regulate the cycle. Continuous low-level heat application and relaxation techniques. Sorry, I hit the wrong spot. And so Iggy mentions that endometriosis is a risk factor for ovarian cancer. So keep that in mind. Pain is the most common symptom, but pain is not necessarily related to the extent of the endometriosis. So say somebody had only the lumps on top of the uterus here and didn't have anything on the ovaries. They might have more pain than a person who had all three of these areas. So the amount of pain the patient has doesn't necessarily mean how extensive their disease process is. And surgical removal may be needed to remove these tissues if the treatments over here do not work, and any adhesions that form may be needed to be removed. And what an adhesion is like a connection between the tissue and the wall of the abdomen in this case. So kind of there may be a growth between the two. We may need to remove that as well as the tissue that is in the wrong area. Then we also have vulvovaginitis, which is inflammation of the lower genital tract. As you see down here, here's the uterus. We're talking about this area. And symptoms can include itching, vaginal discharge change, odor or lesions. And common causes can range from bacteria, fungi, STDs, and these are kind of two examples here in the picture. So there's not just one organism, there could be many. Interventions depend on the cause, so we would need to determine what type of inflammation we're dealing with, determine how we're going to treat it. Overall, though, some things that could be helpful include wet compresses, the sitz bath, which is what the patient sits on and it kind of sprays up to them. That can be comforting. So as topical estrogen or lidocaine applications. And to prevent vulvovaginitis, it's usually recommended to avoid tight-fitting clothing. I don't know what flitting is, but avoid tight-fitting clothing. And wearing cotton underwear. We wear cotton underwear, not avoid it, because it allows the area to breathe. And again, the interventions will depend on the specific organism. So the pharmacological agents can be ordered as appropriate. For example, if it's a fungal infection, antibiotics are not going to work. Determine that. And symptoms can lead to an itch, scratch, itch cycle. So patient may be feeling the itching that we talked about in symptoms and want to scratch the area, but that'll only make it worse. So we want to encourage them to leave the area alone. We also have toxic shock syndrome, which is a severe illness caused by a toxin. And it's often associated with leaving a tampon in place too long, but that's not the only reason it could occur. But symptoms could include hypotension, low blood pressure, fever, rash, flu-like symptoms, or skin healing. Treatment, remove the infection source. For example, if it is a tampon, take that out. Restore fluid and electrolyte balance. Increase blood pressure. IV antibiotics may be used. And toxic shock may come from menstruation and tampon use, or a surgical wound infection, non-surgical infection, gynecologic surgeries, and internal contraceptives. Other treatment measures may include transfusion, reverse low platelet counts, and or corticosteroids to treat skin changes. We have uterine fibroids, which are benign, slow-growing, solid tumors of the myometrium, and the myometrium here. See pictures here. These do not usually cause pain, but they can worsen menstrual cycle symptoms. And these may lead to urinary frequency, infertility, non-menstrual bleeding, and an enlarged or palpable uterus. You can see how these are kind of pushing out, and they could actually grow so large that the patient could appear pregnant even if they are not. And because these are in the uterus, they may increase during pregnancy and diminish during menopause. And we often may have to have surgery, and there are kind of a couple of options, including the minimally invasive surgery, also known as a myomectomy. This is a removal of the leiomyomas, or the fibroids, from the uterus using a laser, which can preserve fertility, the patient's later ability to have children, The alternative surgery is a hysterectomy, where we're removing the uterus, including the cervix, and this can be done through the vaginal canal, right? Or abdominally with laparoscopic or robotic assistance. And there are a couple of charts in your book that can be helpful. Post-operative nursing care of the patient after an open total abdominal hysterectomy, and care after a total vaginal or abdominal hysterectomy. And you may have seen the abbreviation TAH, standing for total abdominal hysterectomy. That's where, again, the uterus and the cervix are removed. You may also see TAH, total abdominal hysterectomy, paired with BSO, and that would be bilateral salpingo-oophorectomy. See why we like our abbreviations. But total abdominal hysterectomy, talked about bilateral, the B meaning both sides. Salpingo is the fallopian tubes. Ask me how we got there. Salpingo, fallopian, I don't know. The oophorectomy would be removal of the ovaries, not an ovary. So, then yeah. There are some other female cancers that are not related to the breast, including endometrial or uterine cancer, which is a cancer of the lining. The endometrial forms the uterine lining. Main symptom post-menopausal bleeding, the bleeding after the menstrual cycle has completed for the patient's lifetime after they've gone through menopause. How do we diagnose this? We look at a CBC, checking their blood counts, and looking for tumor markers. And we may also use transvaginal ultrasound or endometrial biopsy procedure. Interventions could include surgical removal of the tumor and or staging of the tumor and adjacent lymph nodes to see if the growth has spread. And there's a table in your book that talks about endometrial and cervical cancer because they have some similarities. And endometrial uterine cancer is strongly associated with prolonged exposure to estrogen without progesterone, because progesterone acts as a protective measure with estrogen. And chemotherapy may be used as a palliative treatment in advanced or recurrent disease where it has spread to distant parts of the body. Caucasian women have been known to get the disease more often than African American women, but African American women tend to die more often from endometrial uterine cancer, and the causes for these differences is not known. We talked about the chart in your book that looks at endometrial and cervical cancer. So here's cervical cancer, malignant tumor of the cervix. So we can kind of see it in the lower part of this picture. Symptom would be painless vaginal bleeding, and most cases of cervical cancer are caused by certain types of HPV, the human papillomavirus. So screening tests, including the PAP test, or Papin-Colau test, that's what we call it, PAP test, a colposcopy, LEAP, laser therapy or cryotherapy may be used. If the PAP results are abnormal, a colposcopy may be used, where acetic acid is applied to the cervix and examined under magnification with a filter. You have LEAP, the loop electrosurgical excision procedure, where electrical current is used to cut away some of the tissue. Or laser therapy, where laser is absorbed by the fluid in the tissues and the tissues vaporize. Or cryotherapy, where we try to freeze the tissue, which then causes necrosis. Treatment can include a total abdominal hysterectomy, TAH, paired with radiation or chemo for invasive cancer. And the combination of chemo and radiation show an increased survival time, but this can also lead to increased toxicity for many patients, unfortunately. And we have ovarian cancer. So ovarian cancer has the highest death rate of all female reproductive cancers. And this seems to be disordered growth in response to exposure to excessive estrogen. And while this has the highest death rate, ovarian cancer, it is not the most commonly occurring. It is not the most commonly occurring. Let me restate that. However, it's mostly asymptomatic, with only vague symptoms may be detected, so it's most often diagnosed at a late stage, which makes it more difficult to treat. And this results in epithelial tumors growing on the surface of the ovaries. This kind of gives you a point of comparison. One normal ovary, one cancerous ovary. And the tumors grow and spread rapidly. They're often bilateral. This picture just shows, for comparison purposes, one normal, one not, but it's often bilateral, so often on both sides. And treatment could be surgery, either a laparotomy, which is an exploratory abdominal surgery to diagnose, treat, and stage the tumor, or a total abdominal hysterectomy, TAH, with the BSO. Total abdominal hysterectomy with the bilateral, both sides, salpingo, the fallopian tubes, oophorectomy, ovary removal. And this has the highest death rate of female reproductive cancers, and survival rates are low because ovarian cancer is often not detected until its late stage. And so it's important to teach our patients if they're having any type of vague symptoms, especially in the abdomen or the GI system, to come in and get checked because it could be ovarian cancer. Then male reproductive disorders. Now, we have a couple of reproductive disorders involving the prostate. And the prostate is kind of a donut-shaped organ, and the urethra will go through the middle of where the hole is in the donut, so to speak. And so if the prostate gland expands, this can then obstruct the urethra like you're seeing in the image here. Here's a normal image cross-section with the urethra passing through the center of the prostate. But if the prostate is inflamed or swollen, you can see how that could pinch off the urethra. And there's two causes for the prostate to get inflamed or enlarged like this, one benign, one not. For now, we'll talk about the benign prostatic hyperplasia. And this will result in the patient having difficulty starting and continuing urination. So we want to screen for LUTS, L-U-T-S, the lower urinary tract symptoms. These can include frequency, urgency, nocturia, urinating at night, difficulty starting stream, reduced stream, or incomplete emptying, having to strain to begin urinating, post-void dribbling, or hematuria. And we'd want to teach the patient to avoid bladder-irritating substances. They're having a hard enough time going because of the prostate. We don't need to add to it by aggravating the bladder. But such substances could include alcohol, diuretics, caffeine, and avoiding when we want them to try and avoid promptly. They should avoid such drugs as anticholinergics, antihistamines, and decongestants. How could we diagnose this condition? We may look at some urinary studies, such as urinalysis and culture sensitivity, rule out a UTI, because some of these symptoms could also be in common with a UTI. CBC, the blood checking for elevated white blood cell count and decreased red blood cells. Going back to the blood, though, blood and creatinine screening for renal function issues. If the kidneys aren't able to make urine, then that might be why a patient was having trouble avoiding unrelated to a prostate issue. So looking for PSA, which in this case does not stand for public service announcement, but it stands for prostate-specific antigen. And this is one of the things that can help us determine whether the enlargement of the prostate is from this benign condition or prostate cancer. And it'll be elevated in prostate cancer, not in the benign prostatic hyperplasia. So some Medications that could be given for this condition include tamsulosin or Flomax, finasteride or Proscar, doxazosin, Cardera. These help to relax smooth muscle, such as what's found in the prostate. And alpha blockers, such as tamsulosin and doxazosin, can lead to orthostatic hypotension, tachycardia, and syncope. So we'd want to be careful with our patients getting up and out of bed when they're taking these meds. You may have a patient taking saw palmetto as a complementary therapy, but it's not been studied a lot, so there's insufficient evidence to prove its effectiveness at this point. That may change. But some non-medication treatments could include TURP or transurethral resection of the prostate. So if we're going in through the urethra, there's not going to be an incision, but we're going to resect or remove part of the prostate. That's the classic procedure for this type of condition. However, we're getting newer treatments that are becoming more popular, so to speak, including the HoLEP or the holmium laser enucleation procedure, the laparoscopic prostatic adenectomy, and robotic-assisted simple prostatectomy are safer, minimally invasive surgeries that may be performed. So just because something's always been done doesn't necessarily mean it's the best way. We're coming up with some newer things that are less invasive. And there's some charts in your book that talk about post-op care for a TURP patient. That is still the classic one. And patient will probably have an indwelling urinary catheter after the procedure. They may report feeling that urge to void because it's likely the balloon is going to rest right on the sphincter because of where they've had surgery. But we want them to try not to void, because if they bear down to void, they could actually cause bladder spasms. And they may have a continuous bladder irrigation attached to their catheter to help flush out any debris, like blood clots, fibers, anything. So we may see blood-tinged urine to try and flush that out, keep it clear. We'd want to watch, though, for excessive bleeding. Venous bleeding, it may be more common. It's usually going to appear as burgundy, but arterial bleeding, bright red, ketchup consistency with clots, would be more serious, but would want to notify the physician about any bleeding and prepare to irrigate if it has been irrigated already, or turn up the rate. So the BPH was the benign way the prostate could be enlarged. We also have here prostate cancer. So this is the other way the prostate could become enlarged, but it's more dangerous. So this would involve a slow-growing, metastasized, and a predictable pattern. But if it's found early, there's nearly 100% cure rate. Screening would be the PSA, the prostate-specific antigen. So it's going to be increased in this case with prostate cancer. And if the patient is less than 50 years old, the normal range should be below 2.5. We also have DRE, or digital rectal exam. If the prostate enlargement is from prostate cancer, the prostate will present as a stony, hard nodule. And so which do you think would be better to do first, checking for the prostate-specific antigen or the digital rectal exam? Which would go first? Interesting. It's actually recommended to check the prostate-specific antigen first, because that's a blood draw. But if we're digitally examining in the rectal area, we could actually cause more of the antigen to be produced. And so we could actually get a false positive. That's something to keep in mind. Some risk factors for prostate cancer could include advanced age, race, including African American, Caucasian, and Hispanic males, family history, especially a first-degree relative with prostate cancer, and what they mean by first degree would be like a parent or sibling. Just bopping back to breast cancer here for a second, I forgot to bring this up. I have a family history of breast cancer, for example, on my mom's side, but my maternal grandmother and one aunt died from breast cancer, but they are not first degree relatives to me. They are to my mother, so they give her a higher risk because they are first degree relatives. To me, the physician said we'll treat it as a little bit higher risk, but not nearly first degree. But that's what they mean by first degree relative. Also, risk factors for prostate cancer taking a diet high in animal fats, complex carbs, and low in fiber, exposure to toxins, or having had a mastectomy. Going to present as stony, hard, palpable irregularities and durations. Talk about the risk factors. Treatment could include laparoscopic radical prostatectomy, which is the most common procedure. And again, there's a chart in your book about care of the patient after an open radical prostatectomy. Want to monitor for any signs of infection, bleeding, increased pain, or urinary obstruction. Strenuous activities that could increase intra-abdominal pressure would be restricted, such as mowing the lawn. My dad would be disappointed. Lifting more than 20 pounds would be prohibited for 4 to 6 weeks. And the client should take in 6 to 8 glasses of water or non-alcoholic beverages per day to minimize clot formation. And we have testicular cancer, which is actually a pretty rare cancer affecting men 20 to 35 years of age. So very young people involved here. However, with treatment, it has a 95% cure rate. And there are some charts in your book involving testicular self-examination. Like, we encourage women to be aware about their breasts. We encourage men to be aware about their testicles. And charts talks about a patient with a testicular lump. And primary testicular cancer is rarely bilateral, so it's usually going to be one side or the other. If you see it in both sides at the same time, it's likely metastasized from somewhere else. And then we would need to check the immediate areas, such as testes, lymph nodes, and abdomen, checking for whether it is primary cancer or metastasized from somewhere else. Metastatic disease is usually indicated by testicular or bone pain, lymph node swelling, abdominal mass, hydrocele, or gynecomastia. Treatment often could either involve surgery or non-surgical. Surgery would include the orchiectomy, where we are removing the affected testicle. We want to encourage our patients to still perform testicular self-examination on the remaining testicle. And an alternative to the orchiectomy for some tumors may be inguinal surgery, where we may be able to remove the affected testicle via the groin as an intact organ. And chemo may be used as primary treatment in place of surgery or alongside it. So the chemo could be an adjuvant treatment, or it could be a whole nother treatment. So, that a case study, male reproductive health. So RW is a 63-year-old banker who is seen by his healthcare provider for his annual physical, and he reports he's been having trouble with urination since it seems to take longer to initiate a urine flow and longer to actually expel urine, and he states he has to get up several times a night to urinate. And RW is 5 feet 10 inches tall and weighs 220 pounds. His past medical history includes hypertension, chronic atrial fibrillation, osteoarthritis of his knees that prevents him from participating in physical activity. His current medications include metoprolol, a slow pressor, warfarin, Coumadin, and acetaminophen, Tylenol. So how will the healthcare team determine whether his prostate enlargement is from BPH or prostate cancer? Select all that apply. A. Examining the prostate through a DRE, digital rectal exam. B. Collecting a blood sample to check his prostate-specific antigen level. C. Collecting blood sample to check the troponin creatinine. D. Collecting a urine sample to check for ketones. And or E. Palpating the scrotum and testes to check for a mass. So we got some variety of answers here. They actually want A. Examine the prostate through a DRE, digital rectal exam. B. Collect a blood sample, check for the prostate-specific antigen. And C. Collect the blood sample to check for the bun and creatinine levels. So A, B, and C here. Performing a DRE will allow for detection of the enlarged prostate. Benign prostatic hyperplasia will present as a uniform, elastic, non-tender enlargement, while prostate cancer will present as stony, hard, with palpable irregularities. And collecting a blood sample will help us check the PSA, or prostate-specific antigen, which will be enlarged, or elevated, with prostate cancer, but not BPH. And then collecting blood also to check for the bun and creatinine allows to rule out kidney impairment, which would be more specific for kidney function between the bun and creatinine if you had to pick one. Throw in a renal question here. Yep, the creatinine is more specific for kidney function. And making sure you guys are still with me. And if we were checking a urine sample for ketones, we wouldn't be looking for BPH or prostate cancer, but what would we be looking for ketones? Yep, diabetes, because that could indicate they were in DKA. Just throwing a couple other ones out there. And then palpating the scrotum and testes would be more testicular cancer. So the nurse examines RW and finds the prostate gland is symmetrically enlarged, elastic, and smooth. So benign prostatic hyperplasia is suspected, and his prostate-specific antigen, or PSA, level comes back, and his result is 2.3. And his CBC, complete blood count, CMP, complete metabolic panel, and your analysis results are within normal limits. So when RW calls the next day to ask about his lab results, which one of these do we tell him? A. His PSA levels indicate his prostatic enlargement may be caused by a carcinoma. B. He has some mild kidney impairment caused by back pressure of the urine on his kidneys. C. His results are within normal limits, supporting the diagnosis of BPH. Or D. His blood is more dilute than normal because he's not eliminating enough fluid as usual from the urinary tract. It is C here. His results are within normal limits, supporting the diagnosis of BPH. Is the primary methods used to diagnose BPH include history and physical exam. So his physical exam findings are more in line with BPH, and then his additional diagnostic tests are as well, because his renal or kidney studies are actually normal because the abundant creatinine will be part of his metabolic panel, and the urinalysis results do not support a UTI, and his CBC would not indicate increased white blood cell count, and his prostate-specific antigen is 2.3, which is below the threshold of 2.5. So RW's urinary obstructive symptoms are relieved to some extent with the addition of tamsulosin or Flomax. However, his symptoms gradually worsen and he is scheduled for prostate surgery. He is to undergo a transurethral resection of the prostate, so known as a TURP, and is concerned about his sexual functioning following surgery. So if we're educating him, what would be the nurse's priority intervention for alpha adrenergic receptor medications such as tamsulosin or Flomax? A. Safety falls precautions. B. Obtain an order for INO. C. Instruct the patient to take the medication on an empty stomach. Or D. Instruct the patient to always take the medication first thing in the morning. This one is A. Safety and falls precautions, because tamsulosin and some of the other meds are alpha adrenergic receptor medications, and these could have side effects of the orthostatic hypotension, tachycardia, and syncope. So we want the patient to be careful standing up, especially from lying down, and changing positions. So we'd be concerned about safety and falls. And not saying that it's asking for priority intervention. So I'm not saying order for INO wouldn't be something we would want to do, because we know they're taking a medication to help with their urination and their prostate, so we'd expect to see increased output if it's working, but safety and falls risk would take precedent for priority. So as we're admitting RW to the medical surgical unit, he tells you he's recently married after being widowed for 12 years. He's afraid his relationship with his wife will be impacted if he can't perform. So your best response to his concern is to A. Have the surgeon explain the expected surgical procedure and its impact on sexual functioning. B. Ask his wife to reassure him that she loves him and doesn't mind about any dysfunction he may experience. C. Inform him erectile problems are uncommon following a TURP, but some retrograde ejaculation may occur. Or D. Explain why achieving an erection is possible during a TURP, or following a TURP, during it. Long-term incontinence may be a greater threat to his intimate relationships. What do you think? Alright, so I got some variety of answers here. Okay. So, yeah, for some reason it took me back up to the top here. The answer here is C. Erectile problems are uncommon following a TERT, but they may have some retrograde ejaculation, which would mean the semen would go the wrong way. It would go up instead of out. Ejaculate may be decreased in amount, absent, or totally absent, and may affect fertility. And short-term incontinence may occur following a TERP, but long-term incontinence is rare. So that's a question we could answer. If they had more in-depth questions, then we may call on the surgeon. But if we could answer his question up front, that would be the best response. But the other two are not accurate. So he has his surgery and returns with maintenance IV fluids running and a triple lumen urinary catheter connected to continuous bladder irrigation, CBI, with sterile normal saline, and the catheter tubing has light red drainage with a few small clots, and the irrigation is ordered to be kept at a rate to keep the urine light pink. And 2 hours after his return to the unit, RW asks you to check his catheter for leak because his bed feels wet. But you find the linen under his hips saturated with pink tinged urine, and we further assess him for which of the following: A. Atonic bladder, B. Bladder spasms, C. Hemorrhage, or D. UTI. Yeah, this one is B. Bladder spasms. And bladder spasms are a distressing complication after having a procedure transurethral, so through the urethra, and can cause urine to leak out around the indwelling catheter. So the catheter is in place, just the spasm is pushing urine out around it. So the most likely cause of the problem is A. Clots in the catheter, B. Hyperperistalsis and abdominal pressure, C. Traction on the catheter, or D. Renal calculi. What do you think is the most likely reason we're having the bladder spasms? So bladder spasms can occur from irritation of the bladder mucosa from either insertion of a rectoscope, the instrument helping to open the area, presence of a catheter, or something leading to obstruction in the catheter. So if bladder spasms develop, we want to check for anything that could cause a blockage like clots, just to make sure. And the bladder irrigation is intended to help keep the catheter free from obstruction such as clots, or get rid of them before they're large enough to form a blockage. But it could be other substances like fibers or other blood cells. And so what would be the nurse's next action if it is determined that there are clots in the catheter? And what would the nurse do next, do you think? What if they wanted to increase the bladder irrigation? Who would they have to contact? just want to refresh because I wasn't seeing anything there. If they'd have to get an order to increase the rate, just like increasing a rate or decreasing on an IV, because we had an order when he first came up to keep the irrigation is ordered to keep the urine light pink. If we wanted to change that, we'd have to get an order to do so. So we are able to solve that issue, and his CBI, continuous bladder irrigation, is stopped on the second post-operative day, and his catheter is discontinued the next morning in preparation for discharge. But we're checking to make sure he's ready, and we recognize discharge may be delayed if he experiences which of the following? A, reddish voided urine. B, dribbling of urine after voiding. C, an inability to void within 6 hours. Or D, bladder pain and burning on urination. Yep, looks like lots of votes for C, which is correct because after the catheter is removed, the patient should be able to void within 6 hours. If he cannot, catheter should be reinserted for a day or two. A patient may be discharged home with the indwelling catheter, but he'll need more education on its care prior to discharge. And blood in the urine is expected because they had a procedure in the area, and should subside with rest and more fluids. And postoperative dribbling or incontinence is not uncommon, and some bladder pain and urination is also not uncommon because they had a surgical procedure in that area. But once the catheter is removed, they should be able to void, especially within 6 hours. So we plan discharge teaching for the patient, and we want to look at which of instructions would be appropriate for his discharge teaching. And there are 4. So this is a select all that apply. So we have A, monitor for signs and symptoms of infection. B, remain in bed until the incision is completely healed. C, drink at least 2 liters of fluid per day, urinate every 2 to 3 hours to flush the urinary tract. D, if dribbling or incontinence occurs, use Kegel exercises 10 to 20 times per hour. Report any fever, increased redness of urine, or increased pain to your provider. F, since your prostate gland was removed, you do not have to have annual exams. Or G, use daily enemas and stool softeners to avoid straining to have a bowel movement. What do you think? Okay. So we would want A, monitor for signs and symptoms of infection. The next one would be C, drink at least 2 liters of fluid per day and urinate every 2 to 3 hours to flush the urinary tract. D would be next, if dribbling or incontinence occurs, use the Kegel exercises 10 to 20 times per hour. And E, report any fever or increased redness of urine or pain to your healthcare provider. So we would not want B. Why would we not want B? What do you think? We would want to get him up and moving, but what procedure did he have? And we would want to prevent DVT. What procedure? And those are all reasons that he should be getting up and moving around. But remember, he had a transurethral resection of the prostate. So we went in through the urethra, and this says to remain in bed until his incision is healed. He doesn't have an incision. This is when you'd be throwing something at me in the classroom. But as you guys saw, well, you guys were not wrong. You recognize that it's usually not good to stay in bed for extended periods of time. But it was just making sure you were thinking about the procedure. Back to that question. I was making sure, I'm like, did I change what he had done? No. Okay. And then that also with F, he did not have his prostate gland removed. He had it resected. I'm not a jerk, no. But he only had part of it, so he would still need to have examinations done, and it does not completely remove the prostate. And then with G, it says daily enemas and stool softeners to avoid straining. We do want him to avoid straining to have a bowel movement because that puts a lot of pressure on that area. But remember, when you have things strung together like this, enemas and stool softeners, the whole thing has to be correct. And so here, daily enemas would be very harsh on the body. If it just said stool softeners, that may be worth considering, but not an enema daily. But for the correct answers, we do want him to remain, no, we do not want him to remain in bed. We want to monitor for signs and symptoms of infection. We want to drink fluids to help flush the urinary tract. Use the Kegel exercises to help strengthen those muscles back up so the dribbling or incontinence should resolve. And encourage him to report any fever, increased redness, or increased pain. I think he may see some, but if it starts to get worse, we want him to report it to his provider. And RW returns to his provider for a 1-month follow-up visit. And although he reports no trouble with urinating, he does still report some occasional dribbling, uses incontinence pads as a precaution. So we reassure him that should improve with time and encourages him to perform Kegel exercises 10 to 12 times per hour. Okay, so the final exam. So it'll be next week on Monday. You'll have 2 hours for 95 questions. It'll be through ProctorU. Please verify your appointment, check your equipment, because again, there's not a designated makeup opportunity. So, check everything out. Do everything you can to be there for your appointment. And the blueprint is available on Blackboard, as you saw, so you have an idea what sections or where the questions are coming from. And here is just it reproduced. You can see, remember, there's going to be some math there, but most of the questions will come from the breast and reproductive material. So how about for the road? We've got the math problem we used earlier today, but this is done the other way. So it's saying at what rate would the nurse set the pump if the order is for 1 liter of D5.5 normal saline to be infused over 8 hours, and the drop factor is 15 drops per ml. So at what rate would the nurse set the pump? You guys are catching on. They can be figured out either way. One more math for the road. This would be 125 milliliters an hour. Is remember when it says at what rate would the nurse set the pump, even though drop factor is in the question, we don't use it for a pump. I know it can be tempting to use every piece of information, but think about what units you're looking for. That's what you would solve for. Any questions or anything while we're here? Anything comes up while you're studying, please feel free, shoot me an email. Good luck. Tips and tricks for studying. Always remember we have the patient in the bed, with the condition. So think about, how would I recognize what's going on? What signs and symptoms would I see from the disease process? How would I know something's wrong, and how would I identify what that likely is? And then what would I do about it, especially first? And kind of looking at these areas here, now that you've gone through several exams and all of those EAQs, it might be a bad idea to go back to the first couple of units, and with the benefit of the experience with having just had more experience with the questions, now look at peri-op and ortho again and see if it makes more sense. Or if there was a test that didn't go particularly well, or possibly more than one. Again, now that you've had more experience with the questions, maybe go over that material again, and you can kind of use some NCLEX questions as a checkpoint, like diabetes. I think I did okay in diabetes. Let me do some NCLEX questions and see how I do. More disease signs and symptoms. Well, and looking at the breakdown here, the breast and repro, that's going to be your largest chunk of questions, and that is going to be your breast and repro exam. So the breast and repro questions are going to be at the depth you've had on previous exams. Now the other, I don't know how many of these are off the top of my head, other 60-ish questions minus math are areas you've already been tested on individually. So we've had a whole test on each of these areas. So it's going to tend to be kind of the big ideas, main concepts, main disease processes from those areas, but always coming into a patient with this condition. How do you recognize, what's going on, and what would you do about it? So always coming back to that patient care piece. I hope that helps. Because you've already had tests on peri-op through HIV, heme, and oncology. So instead of 40 questions, we're going down to less than 10. So it's going to kind of be the big disease processes, but always coming back to that patient care piece. Okay, well, good luck. You guys have a good evening. If anything comes up, if you have any questions while studying, please shoot me an email. But have a good evening. Good luck.